Hello, I'm Akshay Desai, Director of the Heart Failure Disease Management Program in the Cardiovascular Division at Brigham and Women's Hospital and Associate Professor of Medicine at Harvard Medical School. In the next 45 minutes, I'll be walking you through the approach to diagnosis and management of cardiogenic shock as you review for the boards. These are my disclosures. The broad objectives for this talk are to review the diagnosis, incidence, pathogenesis, and approach to management of cardiogenic shock, including approaches to pharmacologic therapy, use of revascularization for patients with acute myocardial infarction complicated by shock, and the deployment of mechanical circulatory support. It's always useful to begin with a definition, and in general, the operational definition of cardiogenic shock is the presence of marked and persistent hypotension greater than 30 minutes, and hypotension is defined typically at a systolic blood pressure threshold of 80 to 90 millimeters of mercury. If hemodynamic data is available, there's typically a reduced cardiac index, and there are normal or elevated cardiac filling pressures, often defined at a cut point of a left atrial or pulmonary capillary wedge pressure of 18 millimeters of mercury. But clinically, since hemodynamic data are often not available, cardiogenic shock is a syndrome of diminished cardiac output and vital organ hypoperfusion in the face of adequate intracardiac filling pressures. So this is primary pump failure. There are a number of different causes of cardiogenic shock. Most commonly, even in the modern era, cardiogenic shock complicates acute myocardial infarction, and this may be ST segment elevation or non-ST segment elevation myocardial infarction as a consequence of severe myocardial injury and pump failure, or mechanical complications such as ventricular septal rupture, acute mitral regurgitation or free wall rupture, or involvement of the right ventricle. You're all aware that there are also a host of non-coronary causes of cardiogenic shock, including fulminant myocarditis, valvular heart disease, particularly acute valvular heart disease due to endocarditis, trauma or chordal rupture, LV outflow tract obstruction from patients with aortic stenosis or hypertrophic cardiomyopathy, LV inflow obstruction from rarer causes such as myxoma or mitral stenosis, aortic pathology including dissection, pericardial disease such as tamponade, massive pulmonary embolism generating right heart failure and shock, and gradual progression of cardiomyopathy and chronic heart failure may also present with more subacute course of cardiogenic shock. Cardiogenic shock can also complicate cardiopulmonary bypass or may be a result of direct myocardial trauma. In general, the pathophysiology of cardiogenic shock, independent of the etiology, proceeds as follows. There's some primordial myocardial injury that results in myocardial systolic dysfunction. The consequence is a decrement in cardiac output and stroke volume that leads to hypotension. This in turn leads to organ hypoperfusion, including coronary hypoperfusion that activates several systemic neurohormonal mechanisms designed to guard blood pressure. And these further exacerbate the syndrome and downward spiral. As well, because of myocardial dysfunction, there's a rise in intracardiac filling pressures that leads to an increase in myocardial wall stress that generates worsening hypoxemia that further exacerbates myocardial ischemia, leading to progressive myocardial dysfunction and ultimately death. What's often less recognized is that there is a companion systemic inflammatory response that's mediated through numerous cytokines, including IL-6, TNF-alpha, and nitric oxide, that may further compromise cardiac output and perfusion by blunting vasoconstrictive responses designed to defend blood pressure and exacerbating the syndrome of end-organ hypoperfusion. So the intervention to manage this targets various aspects of the pathophysiology, including aggressive unloading, cardiac support, and reduction in filling pressures. There are a number of myths about cardiogenic shock that we should pay attention to. The first is that the ejection fraction is always low. As you will see as you care for patients with cardiogenic shock, ejection fraction is a poor discriminator of cardiac output, and in some patients with cardiogenic shock, particularly, for example, those with valvular heart disease, pericardial disease, the EF may be only mildly or moderately depressed despite severe hypoperfusion. The magnitude of myocardial infarction, similarly in cardiogenic shock, need not be large in order to create cardiogenic shock, and this is evidenced by the fact that even patients with non-transmural or non-ST elevation myocardial infarction can present in shock. The other myth I think that's important to debunk because it affects the selection of therapy is that the systemic vascular resistance in patients with low output heart failure and shock is always high. In practice, the systemic vascular resistance when measured often ranges from 1,300 to 1,500 dynes per second per centimeter to the fifth despite pressor support. And the ability to augment systemic vascular resistance may be an important compensatory mechanism to support blood pressure. And this may invoke some of these inflammatory mediators that I spoke to you about, and the release of those mediators and vasodilatory cytokines might cause inappropriate vasodilatation in a subset of patients with shock. And this is one of the rationales that girds the use of hemodynamic monitoring in patients with shock, since the selection of therapy may vary depending on the systemic vascular resistance in your patient. Although there's been a lot of progress in the management of patients with cardiovascular disease, and particularly coronary heart disease, the incidence of cardiogenic shock after myocardial infarction has been remarkably stable over the years. And recent data here from the nationwide inpatient sample of patients from 2003 to 2010, nearly 2 million patients with ST segment elevation myocardial infarction, suggest actually there might be a slight increment in the rate of presentation with cardiogenic shock complicating myocardial infarction. On average, over the decades, the incidence is about 8% for STEMI and about 2.5% for non-ST segment elevation myocardial infarction. And this occurs despite the more aggressive strategies for revascularization. For management purposes, there is an increasing use of primary revascularization and mechanical circulatory support that is observable in this sample over time. But despite the deployment of these modalities, survival to hospital discharge is still poor. Following hospital discharge, there's also a heightened rate of mortality for patients with cardiogenic shock compared to those without cardiogenic shock. This is data from 112,000 MI survivors in the NCDR registry. And you'll see that there is a time-dependent risk for mortality following discharge from hospital with cardiogenic shock. Patients with shock have higher rates of mortality at both 60 days and at 1 year, but most of that risk is related to early mortality after discharge. Here the blue lines represent patients with cardiogenic shock. In patients with myocardial infarction, the location of the infarct is related to the risk of shock, with the greatest risk apparent in patients from the shock registry in patients presenting with anterior myocardial infarction complicated by shock, and the least risk in patients with true posterior infarction. The reasons that patients with myocardial infarction develop shock vary. The vast majority are related not to myocardial infarct complications, but to profound pump dysfunction and pump failure. You will see, however, that even in the modern era, there is a significant incidence of MI-related complications, and it's important to be vigilant for these, since the strategies for management, often early surgical intervention, vary widely in those cases from the patients with myocardial infarction-related shock from pump failure. These are the key mechanical complications of myocardial infarction resulting in cardiogenic shock: ventricular septal rupture, rupture of the free wall generating pericardial tamponade, and rupture of the papillary muscle generating acute mitral regurgitation. You'll see that the different complications vary in their timing after the initial myocardial injury, but typically occur within 3 to 5 days following infarct. The incidence is low, but because of the high mortality associated with each of these conditions, recognition early and early surgical intervention are critical. The physical exam findings that are common in each of these conditions are listed on the slide for your study. But I think the key message is that one can identify these complications only with careful vigilance and awareness regarding the potential, particularly in patients presenting with large transmural ST segment elevation myocardial injury. Right ventricular infarction is another important complication of acute myocardial infarction associated with shock to recognize. These are the common ECG findings in lead V4R of ST segment elevation. This is an auxiliary lead that may help you make the diagnosis. The clinical findings are, of course, patients presenting with shock in the absence of pulmonary edema, but with evidence of elevated right-sided filling pressure, such as an elevated jugular venous pressure or a Kussmaul sign. On hemodynamics, with a right heart catheterization, there is markedly elevated right atrial pressure with a steep Y descent and a square root sign in the right ventricular pressure tracing. The therapy of this condition is often focused on maintenance of right ventricular preload, reducing pulmonary vascular resistance to lower right ventricular afterload, optimization of AV synchrony, and inotropic support for the RV, as well as, of course, reperfusion to restore right ventricular function. The medical therapy of patients with cardiogenic shock varies widely depending on the cardiac output and systemic vascular resistance. For patients with cardiogenic shock complicating chronic heart failure, this 2x2 matrix is often useful in differentiating the strategies for treatment. The 2x2 matrix is defined by filling pressures based on the clinical absence or presence of congestion and bedside estimates of perfusion or hemodynamic estimates of perfusion that allow us to categorize patients as to whether they are optimal in the upper left quadrant, warm and dry, or suboptimal, that is well perfused but congested, poorly perfused and congested, or poorly perfused and dry. Based on these hemodynamic subsets, we can begin to select medical therapy. Patients with high systemic vascular resistance and cardiogenic shock are often in that lower right quadrant and can be best managed with aggressive unloading using vasodilators. These are patients who will tolerate vasodilation without excessive hypotension because the systemic vascular resistance is high. Whereas in general, patients with low or normal systemic vascular resistance and low output heart failure are better managed with inotropic drugs that are less potent vasodilators and focus on augmentation of contractility and cardiac output. The general management strategies independent of etiology for patients with cardiogenic shock are listed on the following slide. First, arterial pressure monitoring is important since perfusion is largely a function of mean arterial pressure. As mentioned, since selection of medical therapy may vary based on hemodynamics, pulmonary artery catheterization, particularly in patients with severe hypotension, may help to optimally manage medical therapy and define the subset of patients who are most in urgent need of mechanical circulatory support. Maintenance of oxygen saturation with intubation and ventilation as appropriate is important since this may exacerbate myocardial ischemia. Maintenance of near normal arterial pH to maximize the efficacy of pressor support and minimize further injury to the heart is important. Negative inotropic drugs such as beta blockers are relatively contraindicated. And early echocardiography in patients where there is suspicion for mechanical complication of myocardial infarction is important. And as well, as I'm going to show you, there's a lot of data now suggesting that early utilization of mechanical support in the failing ventricle and reperfusion to restore occluded or ischemic myocardium is important. Broadly speaking, I think we can categorize the three goals of therapy in acute myocardial infarction complicated by cardiogenic shock as to provide some general circulatory support through maintenance of mean arterial pressure, to keep up urine output and diminish ischemia to the end organs, provide ventricular support to reduce filling pressure and reduce afterload, and then to maximize coronary perfusion to minimize ischemia. Some of you may be familiar with this data from the ESCAPE trial looking at routine use of pulmonary artery catheters to guide heart failure patients, and there may be some message here for use of pulmonary artery catheters in patients with cardiogenic shock complicating chronic heart failure. In general, the message here was that routine use of a pulmonary artery catheter in this population did not affect the principal endpoint of days alive out of hospital compared to management guided by the clinical assessment. However, with use of the pulmonary artery catheter, hemodynamic optimization was associated with improvements in quality of life and reductions in mitral regurgitation. There was no safety signal in this trial, suggesting that in selected patients with shock, there still may be value. Realize that patients enrolled in ESCAPE were not those with critical cardiogenic shock, who would be those that we're focused on in this talk. So those data apply less clearly, and we don't have trials of routine pulmonary artery catheter usage in patients with cardiogenic shock. When selecting pharmacologic therapy, as I mentioned, it's important to keep in mind the cardiac output and the systemic vascular resistance. These are the options for inotropic support in patients with cardiogenic shock, and they include dobutamine, which is the most potent of our selective beta-1 agonists, dopamine, epinephrine, norepinephrine, and phenylephrine. The adrenergic agonists vary in their receptor selectivity, and one may wish to select the appropriate agent based on the effect that one is trying to achieve. For patients with reasonable systemic vascular resistance, use of agents that provide some vasodilation for cardiac unloading, as well as augmentation of contractility, such as dobutamine and its cousin, milrinone, the phosphodiesterase inhibitor, may be important. For patients with low cardiac output and pulmonary hypertension, use of milrinone in preference to dobutamine, because of its selective effects on pulmonary vascular resistance, may be important. And for patients in whom refractory shock is present and there's just a need to support blood pressure with aggressive systemic vasoconstriction and inotropic support, use of epinephrine may be appropriate. There has been historically a preference in patients with cardiogenic shock to utilize dopamine because of its inotropic effects, but there is this recent data from the SOAP-2 trial, randomized patients with shock, some of whom had cardiogenic shock, to treatment with norepinephrine or dopamine as the principal or initial pressor support. And there was a signal of harm in the patients treated with dopamine compared to those treated with norepinephrine. And that was particularly pronounced in the patients with cardiogenic shock, where the hazard ratio really favored treatment with norepinephrine. This may be because norepinephrine was associated with less arrhythmias, including atrial fibrillation and ventricular tachycardia or fibrillation. And although this was a post hoc analysis of a trial that included patients with and without cardiogenic shock, some have pointed to this data to support the use of norepinephrine as the first pressor of choice in patients with cardiogenic shock, particularly when the hemodynamics are not well understood. Now, as mentioned, in patients with low output heart failure and high filling pressures, the strategy in general with drug therapy is to warm patients up through either use of vasodilators or inotropes, and then to dry them out with diuretic therapy as one wishes. And if there is a high systemic vascular resistance, there is the option to use not simply inotropic drugs to augment contractility and produce some companion vasodilation, but to specifically unload the heart and recruit myocardial reserve. The options for vasodilation are listed on this slide. The most potent vasodilator of these agents is sodium nitroprusside, which in appropriately selected patients has a marked impact on cardiac output because of its marked impact on systemic vascular resistance. It also has a modest impact on pulmonary vascular resistance and marked reduction in filling pressures. The challenge, of course, with nitroprusside use is the marked effect on systemic pressure, which is often the limiting factor, particularly in those in whom the systemic vascular resistance is not very high. Accordingly, less potent vasodilators may be more useful in other patients. Nitroglycerin is often preferred in patients with myocardial infarction complicated by cardiogenic shock because of its anti-ischemic effects and its effects on coronary vasodilation. Nasiratide is used least frequently among these agents because of the early signals of harm with excessive hypotension that were noted in the early trials. In general, when there is a choice between use of vasodilators to augment cardiac output and cardiogenic shock and inotropes to achieve the same outcome, there seems to be a signal of benefit to use of vasodilators in preference to inotropes. And this is one of the other reasons that use of pulmonary artery catheters in patients with refractory shock might help you select therapies to improve outcomes in patients. One of the questions that frequently comes up is the timing of introduction of chronic therapies such as beta blockers and renin-angiotensin-aldosterone antagonists in patients with shock. And this data from TRIUMPH of patients with refractory shock despite reperfusion complicating myocardial infarction suggests that early introduction of beta blockers and renin-angiotensin-aldosterone antagonists before shock is resolved is associated with higher rates of mortality than delayed introduction. So while these agents do provide benefits in long-term application, premature introduction of these agents before shock has resolved may actually worsen outcomes, a point to keep in mind. One of the great lessons of the last 2 decades in cardiogenic shock and heart failure management has been this observation that at least in patients with cardiogenic shock complicating ischemic heart disease, that myocardial dysfunction may be partly reversible with early reperfusion. Now, part of the reason this happens is because ischemic myocardium may be not irreversibly injured, but might be stunned or hibernating with definitions as provided on this slide. Myocardial stunning is persistent dysfunction despite restoration of flow, and hibernating myocardium is myocardium that's essentially metabolically active but underperfused, so myocardial dysfunction in the context of severely reduced flow. And in both cases, maintenance of perfusion and adequate hemodynamic support may allow time for recovery of myocardial function. And this has girded the rationale for aggressive strategies for revascularization and mechanical support to provide time for resolution of shock. To overlay this strategy on top of our previous diagram looking at cardiogenic shock pathophysiology, if one can relieve ischemia through revascularization, there's the opportunity to interrupt this downward cycle of cardiogenic shock and improve survival, both to hospital discharge and over the long term. The best data supporting this strategy for early revascularization is from the SHOCK trial, which is now somewhat dated, but still is a primary driver of our strategy for at least shock complicating myocardial infarction. And in the SHOCK trial, which randomized 302 patients in the late 90s, to a strategy of early urgent revascularization or immediate medical stabilization with selective use of revascularization. The primary endpoint was overall 30-day mortality, but there was a secondary endpoint of 6-month and 1-year mortality. We saw these results. That 30 days, there was no, which was the primary endpoint for the trial, there was no statistical difference between the revascularization and the medical stabilization groups. But at nearly every other time point that was examined, 6 months, a year, and even at the long-term follow-up, the medically stabilized patients had worse outcomes than those who were revascularized early. And it's this data suggesting potential improvements in long-term survival with aggressive revascularization that has driven the guideline-based recommendations to revascularize eligible patients in all cases, particularly with ST segment elevation myocardial infarction. And one of the caveats to the SHOCK trial data is the subgroup interactions. And although all interactions are post hoc analyses and have to be treated as hypothesis-generating effects, the age interaction is an interesting one. And it suggested that patients who really stood to benefit from earlier revascularization were the younger patients with age less than 75. And this may be a note about the vulnerability to end organ damage and the difficulty of reversing that in the elderly patients with less reserve. So what do the guidelines say? Well, the guidelines say that we should do emergency revascularization with either percutaneous intervention or coronary artery bypass grafting in eligible patients with cardiogenic shock due to pump failure after ST segment elevation myocardial infarction, irrespective of the time delay from onset of symptoms. The other is that in the absence of contraindications, if patients are not in a PCI or CABG-capable center, use of fibrinolytic therapy for STEMI patients with cardiogenic shock should be considered. I want to shift gears for a moment and talk about mechanical circulatory support in cardiogenic shock, since the other approach to medical stabilization in patients with refractory disease beyond medical therapy is really to consider mechanical support. The potential benefits are apparent of mechanical circulatory support, including maintenance of end organ perfusion that may be challenging to achieve with pressor support alone. There's the option to unload the ventricle and reduce intracardiac filling pressures, to reduce ventricular volumes, wall stress, and myocardial oxygen consumption, to augment coronary perfusion and limit infarct size or extension. Then the best review of this is really this 2015 expert consensus statement on the use of mechanical circulatory support devices in cardiovascular care that I've referenced on the slide. So when we think about refractory shock, the patients, the one way to think about it is the amount of support that patients require to maintain a blood pressure. And the more support that's required, not surprisingly, the higher the rates of observed mortality are. And the question is, as one moves to the left of the spectrum, how to intervene to improve clinical outcomes and when to consider use of mechanical support. And as you will imagine, as you get closer to the left end, to the right end of the spectrum, the need to consider mechanical support as a salvage strategy becomes more apparent. The options for temporary mechanical support really include two broad strategies. One is use of percutaneous devices that can be implanted either at the bedside or in the cath lab. These include the intra-aortic balloon pump, use of retrograde transaortic ventricular assist devices such as the Impella or in Europe, the percutaneous heart pump, use of left atrial to femoral artery bypass devices such as the tandem heart system, or use of extracorporeal membrane oxygenation with peripheral cannulation. There are also surgical strategies using some of the same devices that can be considered, but more direct cannulation through a surgical incision, using similar devices or centrifugal flow pumps such as the Centromag, or again, centrally cannulated extracorporeal membrane oxygenation. Differences between these devices we'll focus on in the next few slides, but realize that some devices can be configured for either left ventricular, right ventricular, or biventricular support, whereas other devices are really useful only for patients with isolated left ventricular failure, such as those shaded on this slide, the balloon pump and the Impella. In general, moving from left to right, there is more support, which means more flow, more auxiliary cardiac output, and more opportunity to support both ventricles. So what are the considerations in selecting a device for mechanical circulatory support? Well, one of them is the etiology of shock and the anticipated duration of support, since some devices are more hospitable than others to patient mobilization and long-term use. As mentioned, another consideration is whether patients require support for one or both ventricles, and over time, what is the goal of therapy? Is it to help stabilize patients in hope of myocardial recovery, to bridge them to more durable support until end organ recovery occurs, to bridge them until a transplant or donor heart is available, or to bridge them until a decision can be made about what strategy is part of the end game? Let's walk through these devices individually. The most common device in modern use, and certainly the most familiar to most of us, is use of intra-aortic balloon counterpulsation. This is the traditional mainstay of mechanical therapy for cardiogenic shock. The device is a large balloon that sits in the descending aorta with the tip placed just below the takeoff of the left subclavian. The balloon inflates in diastole to augment coronary and peripheral perfusion, and then deflates in systole, providing some reduction in ventricular afterload. The device has been shown to be effective in acute hemodynamic stabilization, although there has been mixed data regarding impacts on mortality. And it's clear that patients who improve hemodynamics on a balloon pump do have better clinical outcomes. So the use of the intra-aortic balloon pump is typically in patients with ST segment elevation myocardial infarction when cardiogenic shock is not reversed rapidly with pharmacologic therapy, in patients with refractory heart failure due to cardiomyopathy and non-ischemic heart disease who don't improve with inotropic support alone, patients with medically refractory ventricular arrhythmias or mechanical MI complications as a bridge to surgery. The contraindications for use of the balloon pump, since it does augment, it does sit in the descending aorta and augments afterload in diastole, because the balloon inflates in diastole, are significant aortic insufficiency, severe peripheral arterial disease, which might obstruct the passage of the catheter, abdominal aortic aneurysm, since the device may enhance the risk of aortic rupture, and aortic dissection, which because placement of the device may exacerbate or extend the dissection plane. Realize that when you have a balloon pump in place, the timing is critical. The device should inflate at the dicrotic notch to provide diastolic augmentation, marked D on the slide, and deflate at the beginning of systole to provide systolic unloading. And you see this at different places on this slide. You see the unassisted pressures, the inflation of the dicrotic notch, generating an augmented pressure in early diastole, and then the end diastolic deflation that lowers diastolic and systolic pressures on the subsequent beat. So this is a normal balloon waveform, and the timing may need to be adjusted based on the ECG signal or the pressure signal to optimize the waveform. Use of balloon pumps in patients with cardiogenic shock in randomized experiences, although there are not many available, is not generally associated with improvements in mortality. This is the most recent data from the IABP Shock 2 trial, looking at impacts of use of a balloon pump versus medical controls in patients with cardiogenic shock on 30-day mortality. You can see the hazard ratio is neutral with superimposable survival curves and high rates of mortality in both the control and the balloon pump arm. There are 2 points here to make. One is that despite aggressive therapy in the modern era, there is a high rate of mortality at 30 days, nearly half of the patients dead at 30 days from following presentation with shock. And the other is that use of the balloon pump did not influence outcomes materially. Now, why is this the case? Well, we know, as mentioned, that there is hemodynamic improvement with balloon pumps, that cardiac index increases, that lactate, and a marker of end organ hypoperfusion, decreases, and coronary blood flow does go up. And there is an increment in many patients in cardiac output, but that mean increment is often less than half a liter per minute. And this, in many cases, may not be enough to restore adequate end organ perfusion. And because of this, usage of other devices which provide more flow have gone up over time, as you can see on the bottom of this slide, while usage of the balloon pump has remained relatively stable. I think the balloon pump remains still the mainstay of therapy because of its ready access and its availability in most cardiac catheterization laboratories. But over time, as more of these other mechanical support devices become available that provide greater support, their utilization has gone up. So let's walk through those support devices. The first and in common use is the Impella percutaneous ventricular assist system. This is a microaxial flow pump that provides essentially bypass from the left ventricle to the aorta. It is placed through retrograde cannulation of the left ventricle via the femoral artery, much like the balloon pump. The access is 12 to 14 French. And the device provides, depending on the system used and the cannula size, anywhere from 2.5 to 4 liters of flow per minute. There is a larger cannula that can be implanted either in the femoral artery or the subclavian with surgical support using a cut down that provides up to 5 liters of flow, but this is less commonly used. Because the device sits in the left ventricle and sucks blood directly into the aorta, it provides only left ventricular support. And in patients with RV failure, it may actually exacerbate RV dysfunction due to shift of the septum. There is a right ventricular complement to this device in development, but that is available for use in research, but is not routinely available for clinical practice. And there are similar systems made by other manufacturers, including the percutaneous heart pump, that are under investigation in Europe that work on a similar principle. The other alternative to transaortic cannulation is this approach, which is a left atrial to femoral artery percutaneous bypass using a centrifugal pump. In this case, through a large transeptal cannula, a cannula is placed directly in the left atrium to deploy blood to the pump. The pump is then, the outflow is then restored to the femoral artery. So this becomes a way of providing left atrial to femoral bypass. This device can be configured for also for right atrial to pulmonary artery bypass to bypass the right ventricle and provide right ventricular support via the internal jugular vein. And with both cannulas in place, there is the opportunity here to provide biventricular support. This device can also be hooked to an oxygenator to provide extracorporeal membrane oxygenation, which we'll talk about in a moment. The one challenge with this pump is that it is a large femoral venous inflow, nearly 21 French, much larger than the Impella system, and the outflow to the femoral artery is typically a 15 to 17 French device that is threaded to the common iliac artery. So peripheral artery disease is another obstacle for passage of these cannulas in several patients. So comparing these devices, the balloon pump, the Impella, which is the left ventricular to aorta microaxial flow pump, or the left atrial to femoral artery bypass system, we see that there is a variance in ease of implantation, with the balloon pump being by far the easiest, and the tandem heart being the most difficult due to the need for expertise in transeptal puncture. The amount of support that can be provided varies depending on which device is chosen, with the tandem heart being the one that is most easily configured for biventricular support. The Impella, as mentioned, may have options for both isolated LV or RV support. The mode of cannulation is typically percutaneous for these devices, but the tandem heart device can be implanted surgically. And importantly, the size of the cannulas, which affects the risk of limb ischemia, varies widely between the devices. But in general, the larger cannula devices provide greater flow at the expense of greater risk of complications, including limb ischemia and bleeding. In randomized exposure, and we have only small trials to test this, it is clear that percutaneous ventricular assist devices of various types, like the ones I've shown you, do provide greater hemodynamic support. There's a marked, statistically relevant increase in cardiac index and a significant reduction in filling pressures that reflects greater impacts on loading and recruitment of myocardial reserve. However, when one looks at mortality at 30 days, it's really difficult to show any signal of benefit with percutaneous ventricular assist devices over the more familiar balloon pumps, and this has tempered some of the enthusiasm for routine use of these approaches in practice. So let me give you a case. This is a 30-year-old woman at 37 weeks gestation of a previously uncomplicated pregnancy who presents with a 3-day history of pleuritic chest pain. On admission, due to concern for fetal distress, she's taken to urgent cesarean section without obstetrical complications. On closure of the abdomen, she suffers complete cardiovascular collapse with a pulseless electrical activity arrest. Cardiopulmonary resuscitation is initiated with recovery of circulation within 20 minutes, but her blood pressure is 80 over 60 millimeters of mercury, with low pulmonary artery oxygen saturation of pulmonary artery O2 of 40 millimeters of mercury, despite high dose inspired oxygen. The extremities are mottled and clammy, and you're called to discuss options for urgent mechanical circulatory support for stabilization. Which of the following do you think is the best strategy? A, an intra-aortic balloon pump. B, veno-venous extracorporeal membrane oxygenation. C, veno-arterial extracorporeal membrane oxygenation. D, percutaneous right ventricular assist device. Or E, percutaneous left ventricular assist device. So the optimal strategy in this patient should be C, veno-arterial ECMO. And this is because this patient has a cardiogenic shock, which might be related to an amniotic fluid embolus or some other etiology of cardiogenic shock, pulmonary embolism. And the etiology of shock is unknown. Need for immediate bedside hemodynamic stabilization is clear. A balloon pump alone is unlikely to provide adequate support and would not address the hypoxemia that is also part of her clinical picture. This patient with unexplained shock requires urgent biventricular support and pulmonary support that's best provided through veno-arterial extracorporeal membrane oxygenation. So extracorporeal membrane oxygenation is really bedside cardiopulmonary bypass. Typically, it's provided through use of arterial and venous cannulation that allow for venous inflow to a centrifugal non-pulsatile pump for blood propulsion. That venous inflow is linked to a membrane oxygenator to provide gas exchange, and then returned in veno-arterial configurations to the arterial circulation. This device can also be configured in a veno-venous configuration where for pulmonary support, where there is no need to bypass the heart entirely. The advantage of extracorporeal membrane oxygenation is the opportunity to cannulate at the bedside from the femoral artery and or vein without guidance from fluoroscopy. This can be done quickly with inexperienced hands, and there can be a substantial augmentation of flow, almost complete substitution of cardiac perfusion, depending on the cannula size that are inserted. This device does require aggressive anticoagulation, typically monitored, typically with unfractionated heparin, with an activated clotting time monitored to be between 180 and 250 milliseconds, or 250 seconds. As mentioned, there are two potential configurations broadly, although there are many others although there are many variations of ECMO. The first is for patients who require isolated pulmonary support, where there is venous inflow to an oxygenator that's then again returned to the venous circulation so that the heart remains part of the circuit. And then the other is complete cardiopulmonary bypass with veno-arterial ECMO, here shown in peripheral cannulation with inflow from the inferior vena cava and SVC and return to the femoral artery to provide cardiac bypass. This is typically done in patients with combined cardiopulmonary failure. So in general, the accepted indications for ECMO, for VV ECMO, are hypoxemic respiratory failure with a low PaO2 to FiO2 ratio despite optimization of the ventilator settings, including the tidal volume, PEEP, and IDE ratio. Typically, VV ECMO is avoided in those who have prolonged mechanical ventilation due to the risk of adverse outcomes. The other option is, the other circumstance in which it's often helpful is in patients with hypercapnic respiratory failure with an arterial pH less than 7.2. So these are patients who need primarily pulmonary support for oxygenation or ventilation despite maximal ventilator settings. In cardiac situations where there's a need for VA ECMO for cardiopulmonary failure, the indications are typically refractory cardiogenic shock, cardiac arrest, failure to wean from cardiopulmonary bypass after cardiac surgery, or as a bridge to cardiac transplant or placement of a ventricular assist device, typically in patients with biventricular failure or acute ventricular failure where there's not time where there's limited time for hemodynamic stabilization. With regard to the efficacy of veno-arterial ECMO in patients with cardiogenic shock or post-cardiac arrest, there really are no large randomized trials. There are only observational data. These observational data suggest a median survival to hospital discharge that remains low at 41%. The best survival appears to be when ECMO is used to support patients with myocarditis, where survival to discharge may approach 70%. And the benefit appears to be greatest if the time to institution of aggressive support in patients with shock is less than 30 minutes, girding the rationale for aggressive identification of shock and early institution of mechanical support. The problems with veno-arterial ECMO is that it is less efficient in unloading the left ventricle because the outflow from ECMO is typically deposited in the arterial portion of the circulation, effectively loading the ventricle. And because the heart is bypassed, and in some patients with shock there may be limited LV ejection, aortic stasis in the root in particular is a concern with risk for thrombosis. Also, with inadequate LV decompression using veno-arterial ECMO, there is a risk for rise in filling pressures and pulmonary hemorrhage, as well as coronary and cerebral hypoxia if the outflow is delivered to the distal aorta. Complications in clinical practice are most commonly kidney injury and bleeding, with infection, limb ischemia, and neurologic complications being not far behind. So how do one choose whether to pursue centrifugal LVAD support with, say, a surgical or bedside device versus complete support with veno-arterial ECMO? Well, in general, this is defined by a number of considerations, including the expertise at your center, the urgency of and a need for support, whether it needs to be done immediately at the bedside or whether there's time to activate the cath lab or OR staff, the complexity of implantation and the implications of that time delay for getting support to the patient, the anticipated length of support, whether both ventricles or only one ventricle need to be supported, and whether or not, importantly, there's a need to support oxygenation in addition to cardiac output. In cases where there is clear need for both cardiac and pulmonary support, and there is need for urgent intervention at the bedside, VA ECMO is often the preferred strategy, since the time-delayed institution of centrifugal LVAD support is typically greater. The downsides, as mentioned, are the need for more aggressive anticoagulation and the higher risks of stroke, bleeding, and ischemia, as well as the increase in LV afterload that occurs because of less LV unloading with this strategy. One way to mitigate this problem with high filling pressures due to limited LV unloading with VA ECMO and cardiogenic shock is to provide a venting strategy for the left ventricle to further decompress the LV. This can be done with a balloon pump, but it's more typically done in the modern era with devices like the Impella or direct atrial cannulation. Some other strategies for left heart decompression during VA ECMO are listed on this slide, as well as the curves that highlight what happens to hemodynamics in terms of pressure volume loops when a vent is in place. Right ventricular failure, as I mentioned, is a specific case of cardiogenic shock where we have more limited options for urgent mechanical stabilization, since many of the devices are configured primarily for left ventricular support. But there are devices now in development and in use that are appropriate for patients with RV failure. The tandem heart, as mentioned, can be configured for either right ventricular assist device or biventricular support. The Impella has a right ventricular cannula that can be used for urgent RV support, and there are a number of surgical strategies as well as ECMO-based strategies that can be used to support patients with isolated right ventricular failure at specialized centers. In general then, if we look at patients according to the severity of shock, we can grade devices based on the amount of support that's provided. For patients with lesser degrees of shock, devices that provide lesser flow, such as the balloon pump or Impella 2.5 may be adequate, whereas patients who have more severe shock and need more augmentation of cardiac output, devices like tandem heart, centrifugal surgical LVADs, or ECMO may be more appropriate. Selecting devices then really breaks down into whether the shock is primarily related to pulmonary problems and respiratory issues, primarily due to cardiac problems or due to a combination. And you can see on this slide from Seibel Carr and published in Circulation that different strategies may be appropriate depending on the etiology of refractory failure and the amount of support that's required. Once patients are supported temporarily with any of a variety of mechanical circulatory support devices, there's a need to define the long-term destination. In some cases, temporary stabilization may provide a bridge to myocardial recovery and device explantation, but in other cases, shock may remain refractory and wean an explant of these devices without another strategy may be difficult. In those cases, the question is that what is the next step? And the options now include use of durable ventricular assist devices for patients with primary cardiogenic shock. These are either as a bridge to cardiac transplant or destination therapy. Direct to transplant strategies, for example, from VA ECMO if a donor can be identified, or palliation for patients who don't have a durable or long-term support option. These are the options now that exist for durable mechanical circulatory support, and you can see the early generation devices on the left of the slide, the HeartMate XVE. Now the more modern devices, including the HeartWare HVAD and the HeartMate 3 in the lower right-hand corner of the slide. The evolution here has been to smaller devices that are implanted through smaller surgical incisions that provide substantial ventricular support. All these devices require transcutaneous drivelines that do create a risk for infection, since the driveline transits the abdominal wall. And most of them are configured principally for left ventricular support and approved for that indication, though some can be configured for RV or biventricular support. The standard long-term strategy for patients who need chronic biventricular support is still a total artificial heart, although this device is used in limited application in practice and has largely been supplanted by use of veno-arterial ECMO. Selecting patients for different devices really now is heavily based on the INTERMAX profile, which explodes patients at the end stage of the heart failure spectrum into various categories of late-stage low-output heart failure. It's a seven-stage profile that grades patients with refractory cardiogenic shock at one end of the spectrum, INTERMAX profile 1, to those with ambulatory heart failure in INTERMAX profile 7. The candidacy for long-term mechanical support depends on a host of cardiovascular and non-cardiovascular considerations shown on this slide, and thorough evaluations at experienced VAD and transplant centers are important to consider in identifying patients who are truly eligible for long-term MCS. This is that INTERMAX profile classification, now more granular classification provided on the slide, and the shorthands that are applied in clinical practice. The patients for whom durable LV support is indicated are generally those with INTERMAX 1 through 5, although in general the best outcomes are those with INTERMAX 2 and 3, reflecting those who are either stable on inotropic support or deteriorating on inotropic support. Those at the Intermax 1 level of the spectrum tend to be those with critical shock who are probably too sick and in whom temporary support should be considered. Those with Intermax level 4 and 5 are at the margin of the indication and may reflect patients who might be a little too well for durable support but are being considered as the device complication rates go down. And those who are at the best end of the spectrum, the Intermax 6 and 7 patients, are in the investigational portion of the spectrum, likely too well to be considered routinely for mechanical support. What's clear is that use of durable left ventricular assist devices in appropriately selected patients with advancing technology can be associated with improvements in survival. These are data from subsequent trials looking at different generations of left ventricular assist devices, highlighting improvements in mortality from that seen with inotropic support at 1 year, extending to 2 years, that are quite dramatic, as shown on this slide. So the take-home points from this talk are that cardiogenic shock is still associated with high rates of in-hospital and post-discharge mortality. The key point for at least patients with ischemic heart disease is that early revascularizations in patients with myocardial infarction complicated by shock does improve outcomes. For medically refractory patients, there is option for many to use mechanical circulatory support, but the timing and early institution of that support is key to improving clinical outcomes. Device selection should be tailored to the needs of the individual patient and to local expertise, so you need to know what's appropriate at your center to select the appropriate device. Consider the goals of care before transitioning to mechanical circulatory support, because every patient needs an exit strategy, be that durable support, recovery, transplant, or palliative care in patients who don't recover. And patients that stabilize on mechanical support are increasingly thought to be candidates for durable ventricular assist devices, either as lifetime therapy for heart disease or as a bridge to cardiac transplant in the minority of patients who are eligible. So with that in mind, here are some references that may help you in your further study. And I'll close with a few questions that may help you with examples of what may show up on the boards. Here's the first question. A 60-year-old man presents to the emergency ward with 2 hours of crushing substernal chest pain radiating to his left arm, associated with nausea and diaphoresis. On exam, his blood pressure is 82/48, his heart rate is 110 beats per minute, and his oxygen saturation is 95% on 4 liters of oxygen. He is in severe respiratory distress and has marked jugular venous distension, bilateral rales, and an S3 gallop, as well as cold and clammy extremities. His electrocardiogram reveals sinus tachycardia with ST segment elevations in the anterolateral leads and ST depression in the inferior leads. He's given aspirin, nitroglycerin, heparin, and IV fluids. He remains hypotensive despite dopamine. Urgent coronary angiography is planned. Which of the following additional steps is most appropriate? A, initiate a low dose of beta blocker. B, add a 5-phosphodiesterase inhibitor. C, insert an intra-aortic balloon pump. D, administer thrombolytic therapy. E, pericardiocentesis. So the answer here is insert an intra-aortic balloon pump. And the rationale is that answer A, this is a patient with ST segment elevation, myocardial infarction, complicated by cardiogenic shock. That has low output despite inotropic support with dopamine. The patient has a low blood pressure on dopamine at a high dose. Low dose beta blocker would be inappropriate as it may exacerbate shock in this circumstance in a patient requiring beta agonists. A phosphodiesterase inhibitor is a reasonable consideration, but in a patient with low blood pressure may be poorly tolerated, particularly if the SVR is low, and might be a bad empiric choice. Use of a balloon pump for medical hemodynamic stabilization, particularly during angiography, would be a preferred strategy. Alternatives would include use of other mechanical support devices. Thrombolytic therapy would not be appropriate in a patient being taken to urgent angiography, and there's no indication of tamponade to suggest that pericardiocentesis would be appropriate in this patient. The answer is C. Second question. A 65-year-old man with type 2 diabetes presents to the emergency department with 4 hours of chest pain. Physical examination reveals a heart rate of 120 beats per minute, blood pressure of 72/50 with marked jugular venous distension, bilateral rales, and a loud S3 gallop. The extremities are cool. Electrocardiogram reveals ST segment elevation and leads V1 to V4. A pulmonary artery catheter placed at the time of catheterization is likely to reveal A, a pulmonary capillary wedge pressure less than 18 and a cardiac index of greater than 2.2, B, a pulmonary capillary wedge pressure of greater than 18 and a cardiac index of greater than 2.2, C, a pulmonary capillary wedge pressure of less than 18 and a cardiac index of less than 2.2, or D, a pulmonary capillary wedge pressure of greater than 18 and an index of less than 2.2. The answer here is D, a high pulmonary capillary wedge pressure, more than 18, and a cardiac index of less than 2.2. This is a 65-year-old man who's presenting with an acute ST segment elevation, MI, in the anterior wall. The patient is hypotensive and in shock with high filling pressures. The signatures of high filling pressure and cardiogenic shock, the cold and wet patient, are a low cardiac index and a high filling pressure, which is answer D. Third question. A 75-year-old woman with past medical history of hypertension is admitted with chest pain and acute anterior wall ST elevations. She is Killip class 3 on presentation. She receives intravenous thrombolytic therapy and her chest pain resolves. 72 hours later, her chest pain suddenly recurs and she develops respiratory distress and becomes hypotensive. Physical exam reveals a new pansystolic murmur best heard at the left sternal border with a thrill and an S3 gallop. Pulmonary capillary wedge tracings reveal some V-wave prominence, and oximetry reveals the following saturations: superior vena cava 66%, inferior vena cava 70%, right atrial 70%, right ventricular 80%, and pulmonary artery 82%. What's the most likely diagnosis? A, myocardial rupture, B, ventricular septal rupture, C, ventricular aneurysm, D, right ventricular infarction, or E, mitral regurgitation due to papillary muscle rupture. So the answer here is B, ventricular septal rupture. This is a patient with an acute anterior ST segment elevation myocardial infarction who's reperfused, but within 3 days develops sudden recurrence of chest pain and abrupt respiratory distress. This is the typical presentation of an acute myocardial infarction complication. The timing is appropriate, and the exam suggests a new murmur with a thrill and a gallop. There is a V-wave on the wedge tracing, which might make you think about acute mitral regurgitation, but then the saturations really seal the answer with this marked step up in saturations that is from the right atrium to the pulmonary artery from 70% to 82%. That step up in saturations indicates left to right shunt that would be explained by a ventricular septal rupture. So the answer here is B, ventricular septal rupture. A final question. Which of the following steps has been shown to reduce mortality in patients with myocardial infarction complicated by cardiogenic shock? A, intra-aortic balloon counterpulsation, B, percutaneous left ventricular assist device, C, early catheterization and revascularization, D, pulmonary artery catheterization, or E, early cardiac surgical consultation. The correct answer here is C, early cardiac catheterization and revascularization. This is the data from the shock trial that I showed you. Be mindful of the fact that mechanical circulatory support, while important in hemodynamic stabilization, either with a balloon pump or a percutaneous LVAD, has not been associated with improvements in mortality at 30 days, nor has routine use of pulmonary artery catheterization or early cardiac surgical consultation, though both may be helpful in selected patients with cardiogenic shock. The answer here is C. Thank you very much for your attention. I hope this has been useful to your study. Good luck.